So I'm Julie Lemoyne. I've been moderating most of the MedVR talks so far. I'm a co-founder of MedVR, and I've done XR technology for more than 15 years, and I have done advanced technology for about 35 years. Right now, I am a Irish Research Council Scholar at the University of Medical School at UMass at the Shriver Kennedy Center. And I'll probably have my PhD completed sometime this summer. Doing everything in my life backwards, getting a PhD in my 50s and all that kind of stuff. But so let me spend a moment and talk about MedVR. So we're new, and if you got to hear some of Stephen, who was out here, Stephen Patterson, who's the original founder of MedVR, we've been around for about a year, and we're really focused on trying to bring the cross-discipline of advanced technologists and XR technology together with experts in healthcare, from clinicians to pharmaceutical experts, to medical researchers, to hospital professionals, doctors, nurses, mental health specialists, in combination with the technologists and the end users. So it's all about like that cross-discipline nature. And so we spent all of last year doing a full year of webinars. And if you didn't hear Stephen say, this year we plan to push a little bit further into an organized educational curriculum if we can. And we're going to just keep going and growing the knowledge that we can bring, raise all boats in the field to try and build this cross-discipline as much as we can deliver on. We do have a hackathon that's planned for this summer. We're a little loose on what date there. We have a date, but it's likely to change. The other thing I would say is we've had a number of these talks, about 16 of them, and you can see them on the website, the medvr.io. So we are really after this unique, diverse community. And by the way, actually, let me not be remiss in my job here and say, as you brought up, Danielle, we definitely don't do this all out of nowhere. So we'd love to have sponsors. So if you'd like to be in touch with us, we would love to hear from you about sponsorship of any kind to help us, raise all boats with these talks and with our curriculum and webinars and our hackathons in the future. We have an absolutely wonderful talk. Let me just go back up here. Today, and the reason why today is so exciting, I think it's amazing, is that we have both an amazing surgeon and a patient. And so this is the first for us to have an actual both-sided conversation. So we're very, very thrilled to have our speakers today, Ms. Collins and Dr. Jean with us today, and I will go to Danielle to be a little more informal with you. But they're both trailblazers, and in fact, the treatment that Danielle received had a pivot in her career. So we'll hear about her career as well, her pivot in her career as well. I want to stop for a moment before we start and thank Surgical Theater. They're one of the leaders in the XR healthcare service industry. And they are really early cutting edge people that have tied, fighter jet simulation technology with patient anatomy scanning. So their work is tremendous. And they are the organization that brought Dr. Jean and Danielle to us for this talk. I think it's very gracious that they've stepped out of it, but I want to talk that if you have a very deep technical question, for example, something that Danielle or Dr. Jean cannot talk about, they can go pretty deep into this, but they have some folks in the chat who can respond to this. So we've got some Surgical Theater folks in the chat that can respond to that. And if it gets down and dirty into the technology, I'm a technologist, so I can do some of it, but we'll bring them into the talk as well. I think it's worthy of noting that we're going to hear one use case today, but their technology can be used with cardiac, spine, lung, and others. And I do think people should track what Surgical Theater's doing. They're releasing more in the AR area as well. So I think that's pretty exciting for me personally, as well as everybody. I love to work in the AR area as well. So I just want to give them kudos for bringing great speakers to the table. So let me just talk about today. First, I'd like to introduce Danielle, who will be speaking first. So Danielle had a condition. She had AMS in, I think, 2017, if I get the dates wrong. Is that right? Or 2017? Yeah.
AVM and
AVM. Oh, yep. So AVM, sorry. Yeah. In 2017, she is currently the patient and chief experience officer at Empower 360 and is on the advisory board of the International Virtual Reality and Healthcare Association, which I did not know. I gave a talk in Tennessee there last year. She has a master's from the University of Maryland in social work and an undergraduate degree from the University of Georgia. And we are delighted to have her here to share her patient perspective today and what it's done for you. So thank you very much for coming, Danielle.
Thank you, Julie.
My pleasure. And then Dr. Jean, who is amazing, did his residency at the University of Minnesota in neurosurgery, followed by a full-year skull-based surgery fellowship at the University of Cincinnati. He went on to become a neurosurgeon at MedStar, Georgetown University Hospital, and is a professor of neurosurgery at George Washington University Hospital, and is currently the chief of neurosurgery at Lehigh Health Network. So no slouch there. He also has a very active, it's called the Surgeon's Corner, I think, right? Is that right, Dr. Jean?
It's log.
Yep.
Surgeon's log.
Sorry, I thought it was some of the Surgeon Corner, which is very, very actively participated in, and it's pretty interesting. I've been starting to track it myself, although I am not a surgeon. I just play one on TV, I guess. So we're very, very delighted and very lucky to have both of our speakers with us today. I'm going to drop the slides that I have. I want to remind everyone one more time, if you have questions for the speakers, please use the Q&A tab, and then we'll go over those at the end. The way that we've structured it, we have it in 3 parts. Danielle's going to open with her story, the patient's story, and what she went through with XR. Then Dr. Jean is going to talk about the technical components of Danielle's case. And then we're going to go back to sort of the bigger picture. And I don't know when you're going to use the fly through, but whenever you do it, it's going to be wonderful.
Okay.
So we're delighted to see that and have you talk over what it did for you. And then at the end, when we bring you both back, talking about the bigger picture, what it could mean to other people, your other patients, Dr. Jean, and then we'll pop into Q&A. So everybody in the audience will have a chance to ask you some questions. And I think without further ado, that's it for me. I want to just open it up, and I'll help you if you need anything during, and then I'll start off the Q&A when you guys are finished.
Wonderful. So I'll just go ahead and jump in.
Yeah, go ahead.
I'm Danielle Collins, and as Julie introduced me, I am first and foremost a patient advocate directly because of my experience, and I want to take you all back on that journey before I even talk about what I'm doing today. So I'm going to transport you back to June 2017, and I woke up. I started my Monday morning as if it was any other day. Went to a Pilates class, and about halfway through the class, I felt just this incredibly sharp pain in my head. Kind of got disoriented. It felt a little bit like vertigo, to be honest, which I had experienced before, but never a level of pain like this. I ended up leaving the class about halfway through, drove myself home, and spent the next 2 days just in agony and pain. Horrible neck pain, head pain, just the whole gamut. I was even having some spotty vision, really similar to an aura if you've ever experienced a migraine. But I had never experienced migraines before, so it was out of the ordinary for me, but I'm sort of a power through kind of girl. So I kept powering through and saying, it'll get better, it'll get better. 2 days into this, so it was Tuesday evening, my mom, who lives in Atlanta, had sent me flowers. She didn't know how to help. Her daughter's saying she's sick, has the worst headache of her life. She sends flowers, and they get delivered to my next door neighbor's house, who coincidentally just happens to be a neuroradiologist. My next door neighbor texts me and said, I got a package for you. Can you come get it? And my exact words were, Lynn, I have the worst headache of my life. Can I come tomorrow? Well, to me, that phrase didn't mean very much at the time, other than how I was truly feeling. It was the worst headache of my life. But to her, as a doctor, it was a huge red flag to ask more questions. So she started asking about the onset of my pain, where it was located, how long I had been experiencing it, the degree of severity, all of which prompted her to say, if you don't go to the hospital first thing tomorrow morning, I'm coming over myself and taking you. So I did, and I went to a local hospital here in Washington, D.C., where I live, Sibley Memorial Hospital. And about 10 minutes into me being in the ER, the doctor came back to my bedside and said, we're not equipped to deal with this. We had to get you out of here immediately. You have a bleed in your head caused from something called an AVM. And I'm just looking her, like most of you are probably looking at your screens right now, like what does that mean? So an AVM is an arteriovenous malformation, and Dr. Jean will talk in more medical terms about what that entails later on in the talk. But for me, best way to describe it is like a tangle of blood vessels. The hardest part to wrap my head around was that I had been born with it and that I had lived my entire life up until this point with this ticking time bomb in my head. So they loaded me in the back of an ambulance. Everything was sort of a blur at this point. I'm transferred immediately to George Washington University Hospital, where I soon met Dr. Jean and the rest of my surgical team. They started to go over kind of the plan of the trajectory of care and what it was going to entail. And about 2 days into all of this madness, my headache had started to subside. I have very low blood pressure. I'm very fortunate to have very low blood pressure. And so the bleed was somewhat self-contained. Dr. Jean can correct me on this, but this is my understanding. And at that point, I was having a hard time buying into the plan of why I needed to go through potentially life-threatening brain surgery to eradicate something that seemed to be getting better. Like somatically, I felt like I was getting better. But it wasn't until the night before my surgery, Dr. Jean walked into my room and he was carrying a VR headset, much like the one in Julie's background. And he handed it to me and he said, are you ready to fly? And I looked at him like, okay, you're crazy. I'm laying in a hospital bed. Maybe you need to be in this bed and I need to be where you are. But he put the goggles on me, and there aren't words to describe what I experienced. So I'm going to take all of you to see right now exactly what I saw as a patient. So imagine all the fear, imagine all the questions, imagine all the uncertainty, and then imagine someone slipping on a headset and this is what you see. So here I am looking at my brain. I mean, I can tell that's my nose, that's my mouth. Like, this is me. And I'm flying in and I'm looking straight ahead at that orange blob. That's the tangle of blood vessels where it's actually ruptured, the bleed. And the green are the, what's the inflow of blood that's pumping into this AVM and causing it, to grow and to be larger. And then Dr. Jean explained to me that this blue cord that was running toward the back of my brain, toward the, I now know, occipital lobe, was where the outflow was going back to the back of my brain. And I was able to, in real time, like touch the parts of my head and say, oh, that's why my headache is here. And that's why my headache was hurting here. And I was able to ask questions as I'm flying through this fly-through, seeing all the veins, all the arteries, like recognizing my side profile. I mean, it was unmistakably me. If you had a side profile of me today, like I just knew. And I'll stop and come back to you all, but these images were so powerful to me as a patient because it eliminated all that fear of the unknown. And quite frankly, when you're a patient, that's part of the biggest challenge is all the uncertainty and all the unknown factors. When you're thrust into a situation like mine, I felt like I had to learn a new language and learn it really quickly. There's a lot of terms being thrown at me that I didn't understand. There's physical feelings that I'm feeling that don't really correlate with the plan of care that we're talking about. Like I feel better, but I have to go through cutting my whole head open. Doesn't make sense to me. But surgical theater's technology and the way Dr. Jean used it in his clinical presentation to me allowed me to be a part of the plan, allowed me to be a part of the process. And it really eliminated so much of that fear. And quite frankly, too, it did something for my family unit as well. They were all in the room with me experiencing this. We all were as a family unit. This is pre-COVID, by the way. And it allowed them to really see on the screen as I was in the headset, the images that I just showed you and walk through the whole plan so that we all had the confidence that we needed going into this. You're not only putting your life in a complete stranger, quite frankly's hands for the first time, but you're having faith that not only do they know what they're doing, but that they're informing you as a patient and that they care enough to use the greatest way possible that they can communicate what they're about to do with you. And so for me, it was a no-brainer at that point that I had the confidence that Dr. Jean was going to be able to do what needed to be done to save my life. And looking back, I mean, where I sit today, I've learned such a great deal about this, and now I'm very much entrenched in this world. But there aren't words to describe what this does, like I said, for a patient in that moment. And as a doctor, I mean, I take my hat off to Dr. Jean for actually pursuing and recognizing the power of this for a patient, and not only just his clinical practice. So with that, I'll turn it over to him, but I'm so grateful to be here with all of you today, and I look forward to answering your questions and speaking with you a little bit later in the talk.
Great. Thank you, Danielle. Eloquent as always, summarizing what the patient experience is all about. Again, a very beautiful summary of all the issues. I will share my screen now and show you some of the technical aspects of using VR in neurosurgery. This is where I am now, Lehigh Valley Health Network. I have, since Danielle's procedure, become the Chief of Neurosurgery at Lehigh Valley Health Network. My title of my talk is today from patient engagement to the OR, and how this technology has really revolutionized neurosurgery, not just in arteriovenous malformation surgery, but other aspects of it. So what we talk about VR is a technology that turns black and white two-dimensional MRIs and CT scans, the ones that you see on the left side there, into manipulable, rotatable, resettable, drillable, interactable, erasable, three-dimensional objects, colorful objects like on the right. And you can immediately see, as Danielle summarized, the value for patients. Looking at everything 3 dimensions. Patients do not study anatomy, neuroanatomy in 2 dimensions. We spend decades doing that, and that 3-dimensionality right off the bat gives us an advantage of how to tell the patient what's going on, and, as Danielle said, have them participate in their healthcare, such that they're not just a bystander but an active participant. The bottom square now is augmented reality. So instead of turning into just images that you can see in the goggle, now we can have virtual reality objects injected into our operating microscopes such that we can see another layer of reality, the reality that's augmented by these nerves and tumors and arteries to allow us to operate with X-ray vision. And that's the crux of my talk here to follow. Patient engagement, Danielle's always talked about this. So this is the same video that she showed. Again, the value is worth repeating because, again, the value is having the patient understand 3-dimensionality, having him or her direct their own flight trajectory inside the anatomy, and really get a sense of why surgery needs to happen, how it might happen, and how it might affect them. That is in and of itself a tremendous advantage for both surgeons, medical doctors, as well as for patients. So much so that since my move from GW to Lehigh Valley, I have asked for the same technology because it's hard to imagine practicing neurosurgery without it anymore. It's kind of like you've tasted the fruit, you really want it for the rest of your life. It has also moved well beyond that now. Patient engagement is certainly how we started using the technology, but since then, as practitioners, we learn more and more things that we can use it for. So it's a tool that you can use in all kinds of directions, one of which is surgical planning. Staying with AVMs, which, by the way, Danielle explained very well, is a tangle of blood vessels that's abnormal, and is abnormal connection between the arterial system and the venous system, and in this case, inside the brain. So talking about surgical planning with AVMs, staying with AVMs, this not only is good for explaining the anatomy to the patient, but also good for explaining the anatomy to ourselves. So we can look at the anatomy in 3 dimensions to plan surgery. So here is how we traditionally looked at AVMs before we plan surgery. We look at the angiogram and we look at the CT scan, and this is after embolization with a material called onyx, which is very radial opaque and scatters. So you can see that it's very difficult. This is all parts of the AVM that is now treated with onyx and so-called dead. But you can see that on this part, there's still AVM that's very much alive. With these two-dimensional images, it's very hard for us sometimes to tell what part of it is live, what part of it is treated with the onyx already, but not so with three-dimensionality. So in this surgical planning video, you can see that I'm simply just touring the anatomy, and I can see that the turquoise part is where the onyx is already treated the AVM. By the way, the dark blue is your normal motor system and motor fibers. And the green part is still the so-called live AVM that I need to pay particular attention to, because that is the part that can re-rupture and cause problems intraoperatively, whereas the blue part is treated with onyx. I can take a little bit of more aggressive stance on that surgically. So not only is it good for patient engagement, it is also good for surgical planning. But that, again, is yet another tip of the iceberg, because from touring the anatomy, we have gone very, very far along to interacting with the anatomy and so on. So the next phase of this is using virtual reality and augmented reality, not only in rehearsal engagement, but in teaching and in neurosurgical navigation now. So we're moving on to a deeper layer of surgical planning with this paper that we wrote in 2020, and I'll show you what this is all about. This is marrying surgical planning with rehearsal and rehearsal with navigation. So here's a tumor that is very tricky here. It is compressing the optic nerve on the right side. And there are many ways you can skin this cat, so to speak. All right, so first we tour the anatomy, just like we did with that other AVM that we saw. We look at it in three-dimensionality in 360 degrees. And now we can use the tools in virtual reality to practice several different approaches to see which one is best. Here you can see that I'm using the drill tool and quote unquote practicing what we call a supraorbital approach. It is through the eyebrow. We can incision and take the bone off right underneath the eyebrow. And in so doing, we can take the tumor off. Next, we're going to try a different approach called a mini-terional approach. This happens on the side of the head rather than over the eyebrow. And again, we're drilling the bone. We're making the opening as small as possible. And again, this virtual reality tool lets us test really small openings and making sure that they're big enough to take the tumor out without really damaging too much normal tissue. So again, practice, practice, practice. And in the end of the day, for this particular case, we decided that the two approaches were actually equivalent. We ended up choosing this approach, the second approach here, because there are some issues with the patient's eyebrow and anatomy and so on that makes this somewhat more appropriate. Now, what you see in front of you is, of course, a quote-unquote practice of the second approach in virtual reality. What we decided to do is to take this so-called practice thing, make it as a template. So you see the opening of the bone here, you see the dot where we drill the burr hole there. We're going to take this and import it into the operating room, into the microscope. The microscope is tracked by GPS inside the room. So in so doing then, this template, if you will, shows us exactly where to duplicate the opening of the bone in surgery. Now, let's go to the next one. Here's the template. The next thing you will see is an anesthetized patient. The right eyebrow is what you see here. This patient anesthetized. And here you see that we're injecting the template. Here's that blue burr hole. Here's that opening. This is all anatomically tracked and projected through the operating microscope onto the patient's skin. We can then mark where we made that opening in rehearsal onto the actual patient and simply duplicate the opening exactly where we intend it to be as we practiced in rehearsal. So now we're not just operating on the fly anymore. We are simply repeating or duplicating an operation that we have quote unquote rehearsed in the office. We know that the opening is going to be sufficient, wide enough, because we have already done the operation in the office before. So here's a lot of technicality. We open. This might, for the non-medical people, this might actually gross you out. So I'm going to skip ahead. Long and short is that through that already practiced opening, we can take the tumor out without much difficulty, and it leads to a very good result at the end of the day. And here's the end of the operation. And you can see that we did that operation through a very small opening. because we had practiced it and know that it was sufficiently wide to perform the operation safely. And then here is, oh, I was going to show you the incision, but anyway. So the next, so all kinds of usages. And this is the next set of slides is really one of the most exciting ways that we're using it now in the laboratory setting. Not patient engagement anymore, not navigating operations anymore, or duplicating practice operations. But this time around, we're talking about using in navigation, using in laboratory. What if we could actually use this clinical data, such as in Danielle's case, the AVM and whatnot, and transfer it into a laboratory setting to use as study models? Many decades of neuroanatomical research have always used cadavers as these subjects for studying laboratory anatomical measurements and so on. Well, you can understand that cadavers they don't have tumors. You can't find a cadaver that has a specific tumor to study them. So these cadaver subjects for laboratory studies are usually normal anatomy. But now we can take tumor anatomy, AVM anatomy, aneurysm anatomy, and turn clinical data into laboratory specimen. I'll give you an example of how that works. Cadaver, again, has no tumors. You can use patients to study in the laboratory, obviously, because they're not going to allow you to do two approaches to operations just to see which one works better, which one has a wider exposure. But you can actually use those VR models for this. So here are VR models of tumors. This is a whole collection of tumors that have this tumor near what we call the clivus. Okay, and what you see here is that the green is the normal brainstem and the red is the tumor. So having collected a lot of these tumors, they're all somewhat different. We're now using those models to experiment with. We're doing one approach, an approach that's behind the sigmoid sinus and the transverse sinus, to see how much of the tumor we can and cannot see. So you can see the tumor is now removed, so to speak, quote unquote. But now we're going to fly into the skull of this model and see that there are actually tumors left behind because they are blind spots. They are blind spots created by the brainstem, and they're blind spots created by bone that we cannot remove inside the skull. And we can test the volume of the blind spots by simply measuring what's left. Now, same model, we're going to do a different approach, open a different opening, and this opening is in front of the sigmoid sinus, as you can see. And we're going to test this opening's blind spot that it generates. And you can see the blind spot is mostly on the clivus side, not on the brainstem side. And then we can measure and compare these volumes. Now, you say, why bother doing any of this? Well, the reason is that in cadavers that don't have tumors, the measurements are completely inaccurate. Tumors themselves can change surgical exposure. Tumors themselves can change surgical exposure by pushing the brainstem aside, by pushing normal brain aside. And you cannot use cadavers to guesstimate that, estimate that. And this is the only way you can really do that. And this model doesn't care how many operations you want to do on it, because it's just the model. And you can do wild and crazy kind of approaches to test it out and prove to yourself that that won't work, this won't work, but these particular ones would work, and how much blind spots it may or may not generate. Again, it gives you the comparisons of how much blind spot it may have for different approaches and the areas of freedom, et cetera, et cetera. It's a way of using VR that no one has talked about before, and obviously impossible before VR came to be. So all that is the frontier that we will continue to explore. So to say some more about all this, so not only have I now gotten used to using AR and VR to the extent that I cannot do without them, I think the research using these tools will really propel neurosurgery into the future. I am the lead topic editor for a particular issue of Neurosurgical Focus, the entire issue which is focused on VR and AR. We have submissions to that issue that outpace most submissions to most issues. And I actually see a couple of contributors who have submitted manuscripts for that issue in our audience, that there's so many submissions for that issue that we're inundated by it, which means that AR and VR are really being adopted in neurosurgery, and it is a sizzling hot topic, to say the least. And I look forward to a lot of innovations and interesting ideas, exciting ideas to come, not only in this application in neurosurgery, but in other fields as well. So with that, I'm going to turn back over to Danielle and then go to the Q&A.
Okay, so Julie had asked me to speak a little bit about what this entire experience has led me to and what I'm currently doing today. So as a direct result of how powerfully this not only changed physically my life, but also professionally as well. So I'm now the Chief Experience Officer of a foundation called Empower 360. We are based out of Los Angeles, and my partner Diana Judovitz and I are committed. She also has a very personal story why she's so connected to the technologies and quite frankly, surgical theater. But we are committed to providing vital funds for these type of technologies. So not just surgical theater, but beyond. There's so many different applications that can help with physical therapy, or right now, I mean, the mental health crisis with COVID, and we're seeing such an insurgence of those as well. So we're committed to providing vital funds to bring these technologies to the hands of patients and hospitals around the globe. And in that capacity, in my role, I like to think of myself as a super connector, and just connecting the dots between the need and the solution. And that's, you know, what I would love to discuss if I can be relevant or helpful in any way with any of you listening here today. Please think of me as a resource in that capacity.
Well, I have just a quick question about that. Just so it's clear.
Yeah, go for it.
Yep. So what's the goal of the organization? Do you seek out medical institutions and help them get the equipment that makes sense? Or tell me a little bit more about the goal of the organization.
So we work, I mean, we're a combination of philanthropic individuals and strategic partners, as well as doctors. And we have a pretty robust advisory board that spans, you know, everything from clinical practitioners as well as tech individuals. And we really do want to make it easy and accessible to bring these technologies to hospitals, as well as I wanted to mention Dr. Jean has personally been a recipient of one of our grants that we give called the Visionary Grant for his global pursuit of training the next generation of neurosurgeons around the globe using VR technology, specifically surgical theater.
So what we've done is actually, through that funding, taken trips to low to middle income countries, developing countries, and show the technology and its application in neurosurgical procedures in those countries. So, you know, we go to Vietnam, we go to Panama, we go to other places in the future as well. COVID kind of made a mess out of that. But you know, there's unlimited ways that we can spread this technology, developing fellowships that train doctors to use this equipment, you know, and so on and so forth.
Exactly. And our website, you know, if you visit empower360foundation.org, you can get a full spell out of all the grants that we give that range from research grants to visionary grants to leadership grants, and those typically fall more on the institutional side. We have also endowed a chair who's practicing out of Hoag Hospital in Southern California in Newport Beach. So it really is about just creating access for patients, for providers. We want to champion these efforts, and we want to also help those who want to conduct further research on how development can take place to be, you know, sort of the strategic partner behind all of that.
All right. So, Dr. Jean, would you like to talk a little bit about other use cases and how you're seeing it with your practice today? Like, is it exponentially growing your use, or what are you seeing as far as, I guess what I'm mostly interested in is outcome. Like, if using this with patients, are you seeing improved outcome with patients? And are you, how much are you tracking that? I know it's only been a few years here on this, but what's the, is there research that's coming out on the efficacy? in that.
That's the golden goose.
Sure.
You know, it's very hard to track outcome because once you have the technology, you have to go back to a control group that does not have the technology.
And then you're a
you know,
barbarian, right?
how do you deprive people of something
Yeah.
that you think really works, right? One of my good colleagues, Rob Lewis, has done a study using VR versus non-VR and consent process, and this consent process is now with the control group, historical control, and as well as you know, different time periods of controls. He's shown that the consent process is a lot better with VR because patients really understand much better than using non-VR consent process. For clinical, it's extremely difficult to do that, but because you have to match cases that are historical to your current cases in order to have a control group to say that the outcome is different. Again, ethically, that's kind of hard to do going forward. You can't deprive people of technology that clearly you think is worthwhile and useful to just do how you have a control group. But I can tell you that even if I can't prove that it is safer and more efficient and all that, what it has done for me is that it made me a little bit more, quote, daring, unquote. Now, that's a terrible, loaded word to use in front of this audience. It doesn't mean that I'm being cavalier with this technology. What it means is that without the technology, I would be very hesitant to do a small opening because I would say, oh, I may not have enough room to get there. And what if something happens intraoperatively? So the conservative thing to do always is have big openings so that you have full control of the operative field in case something happens. With duplicating surgeries that I already practice in the VR setting in the office, and plus the experience of having done several approaches and choosing one over the other, the confidence of doing operations through smaller and smaller holes is higher and higher and higher. So it benefits the patients because this is minimally invasive. You're not doing huge incisions and huge openings anymore. You're doing small and small openings. So my confidence generated by this is yet another layer of benefits that these patients are having. And you're comparing apples oranges now, because, you know, in the old days, I used to do the same operations through a much bigger opening, much more invasive opening. Now I'm doing a small opening with the same results. How do you compare that? It's comparing completely cantaloupes and pineapples. So it's extremely difficult to track outcomes in that regard.
One thing that is important to track, though, you know, and I'll give the patient voice here, is the choice on where you're going to have the surgery. And ultimately, one of the things that the institution cares about, and it's something we don't like to talk about a lot, but is that a surgeon gets paid if they do an operation, and the hospital gets paid if the patient stays there, right? So in my case, being in Washington, D.C., I have a handful of hospitals that I very easily could have elected to go to. And weighing those options, none of the surrounding hospitals had this technology at that point. And so for me as a patient, I decided to stay, and I decided to place my confidence in Dr. Jean as a surgeon because I knew that he was equipped with the best technology there was. And I felt that it empowered me as a patient to make that decision, an informed decision, which ultimately affects, you know, the outcomes for the hospitals and as well as the surgeons and all the nitty-gritty stuff that we don't like to talk about very much. But those things with regards to outmigration for patients can be tracked.
Yeah. Well, I have a plethora of questions, if you don't mind going into them, unless you wanted to talk some more
Sure.
in particular. But so we've had a couple of AR surgeons working on knee recovery, knee replacement and things like that have spoken, and they've talked about that placement of the template and that the patient can move. So Dr. Jean, I think it's for you, like that placement with AR that you showed, how difficult is it with the equipment that you're using? And we have one person in the Q&A that's asked, like, what equipment are you actually using? You know, like,
well, I'm using surgical theater, okay,
yeah.
And the re-registration of the anatomy takes place on the fly and almost constantly, especially when you have doubt that there might be some registration and spatial errors. Very simply, with the microscope, all you need to do is bring in the probe, the navigation probe. The AR actually has a virtual probe, an AR probe, and as long as that AR probe and the real probe is aligned, you know your navigation is spot on. So there's absolutely no doubt there. When you use the endoscope, it's a little bit more difficult, but simply put, that tracking that, co-registering that virtual or augmented probe with the real probe is how you check the anatomy all the time.
Okay. Yeah. And the model itself that's created that you place, and even the one that you go through with the patient, how long does it take to construct that? So there's a lot of processing that occurs, but the construction of that versus when you can use it, can you speak to that?
Yeah, the rendering of the anatomy from 2D into 3D takes usually about 10 to 15 minutes. The program leads from surgical theater are wizards at all this, and they do it very, very quickly. So if the MRI is right, the patient can be in the room talking to me, and then they're reconstructing this into 3D. And by the time I finish my discussion, the 3D model is ready for the patients to look at for their specific anatomy. With regard to segmenting tumors and optic nerves and normal structures and veins and arteries and all that, that can take a lot of time. And it's anything from minutes to hours, depending on how detailed you want and what kind of structures you want. In terms of registering and using AR in the operating room, no time whatsoever. Once you segmented or color those those objects that you want to inject into your microscope, bing, bang, boom, it's already injected. It does not add much operating time whatsoever.
Great. And then there's a couple more that I have, but let me go to some of the Q&A from the audience. I think this is a really good one for both of you. That do you do any kind of screening to see who might be comfortable with VR? And is there a patient side to this and a doctor side to this? Do you do something before you start to use the technology with someone?
Well, I can address it pretty quickly. I have yet to have anybody refuse to see their anatomy in 3 dimensions. So there are several aspects of this, right? One is the conversion from 2D to 3D and color, okay? And you can look at that 3D in goggles versus on a flat screen, right?
Sure.
I have people who refuse being in the goggles because they do get dizzy. I have not counted how many, very few to be sure, but a lot of people just prefer to look at their anatomy on the screen and that explains enough to a patient, and they don't need necessarily to be in the goggles. Is there screening? You just simply ask whether they're comfortable using it, the goggles or not. And there are those who will say, well, I do get C6, or I'd rather not, but again, it's very rare. There's a question related about how, using this technology, teaching surgeons using VR on 3D versus on a screen. Again, there's tremendous value just doing it on a screen, because you can again convert a 2-dimensional anatomy on CTs and MRI scans into 3-dimension in and of itself. That's already useful, whether it's on a screen or VR. The benefits of teaching residents and trainees in VR in the goggles is that now you can use the tools in VR space to change anatomy. You're drilling, you're erasing, you're manipulating, whereas on the screen it's a little bit hard to do that. You can do that on screen, but it's much easier in the goggles.
Yeah.
So
from a patient's perspective, I'll just chime in here and say I have people hounding me, for my family member had a brain bleed, my family member has a tumor, I've had actually one of my best friends that I've known since college that had to go through brain surgery. It was a very public case. And when she knew about my story, they actually flew up, surgical theater did, a program lead, who at the time was my brother, and allowed her to see with her surgeon her case in 3 dimension. And she just, could not say enough about what an impact and a difference it made for her deciding and electing to have the surgery. So
I think, let me ask about that right there. I mean, so I wanted to ask a little bit about cost and about the notion of COVID, and I wanted to sort of tie it together and ask if you were doing something like, okay, because of COVID, we can now send you this headset with something in it that was constructed in another system. Like, are you, you said COVID's tough on everyone, but the notion that you can pop something into a headset and get it to a family member or to another surgeon are you seeing that kind of a use case start evolving, or is that just pie in the sky at this point still? You're not taking what you're getting and dealing with COVID in an easier way as a result of this technology?
I think that's a great question for the surgical theater team, but
yeah, I agree.
But as well, I do know, I can speak because I've spoken with other surgeons who are using this technology, is that they're still able to share these, correct me if I'm wrong, Dr. Jean, but still able to share these 3-dimensional renderings on a 2D screen, even if it's through as simple as what we're doing today with a Zoom screen share. Okay. And even just having that rendering in a separate way to be able to see, you look at the 2D DICOM images, like it's night and day different. whether you have a VR headset on or not. So
Okay.
that is possible currently.
All right. And then before we go full on and just into the Q&A questions from the audience, I just wanted to ask you both to comment on what you think is really missing right now, or what is something that has to be solved. And I will put forward, so Walter Greenleaf, when he was talking to us about doing surgery with AR and VR, he said, you know, you got to remember that we're going to have AI assisted surgery someday soon, you know, relatively soon, and robotic surgery. So the notion that the surgeon is determining the path and they're aided by AI and robotics to get the work done on the body, right? But I you know, because haptic always comes up, and, you know, this training and whether or not then you know, you can do good enough training, and should you use it for the first 2 years and the last year the students get cadavers or what have you, right? So I'm interested in what you think is really missing and isn't there yet, that will just is really important to you. What are you seeing that's missing right now?
Is wide scale adoption a fair answer?
That's a fair answer, especially from a patient, right?
And full reimbursement, you know, for these services as well.
Interesting.
That question is worth about 2 hours of discussion, and there's so many layers. I'm a pragmatist. I don't have a crystal ball, and I think that question is so multi-layered that it's, you know, it takes a supercomputer to really answer that question fully. I can speak as a pragmatist what the immediate next steps could be, and these are sort of imaginary sort of things. Let's forget about haptics and training residents and young surgeons with simulators for a second. I think what can happen relatively soon is that someone like me sitting in Allentown, Pennsylvania, using HoloLenses or something like that, can see an active operation in, let's say, Mumbai. And they're using the HoloLenses as well. And I can actually see their operating room and see what they see. I can then use a marker or a pen or an instrument to draw on the virtual patient in front of me, and they will see a yellow line, a purple line, a blue line, that I can then say, okay, this is where the incision should be, or this is where the bone opening should be. And whatever I draw on that virtual rendering, I see through my HoloLens, they see through their HoloLens, tracked with anatomy, tracked with navigation, and painted on the patient in the exact position that I drew it in. So that so I can basically coach someone who's through the internet in a world half a globe away.
Right, so like remote consult, right? OR remote consult.
That's one thing. The other thing is oh, I've lost the train of thought.
Sorry.
There's again, being the lead editor in that journal, particular issue, I'm seeing now people pushing the envelope on using augmented reality for navigation and skipping the traditional navigation, the electromagnetic navigation type. So it's going to change navigation in the operating room dramatically, because you can actually render objects and use those objects as your fiducials, if you will, to track objects without using this very expensive navigation equipment that we have now. That's another advance. And really, there are many other areas that this is going to evolve into. Oh, robotics. Yeah, so you can see that if I can have a template as primitive as our template now, the templates can get more and more sophisticated. So this template, I put a marker here, that's step 1, a marker here, that's step 2, a marker here, that's step 3. So the future operation can be turned into trace by numbers, right? Like my 5-year-old does. And once you can trace by numbers, then a robot can be able to trace the numbers. So then you're really evolving into robotics in brain surgery. So yeah, all that is possible, and probably in the very near future.
Yeah. One of the other things I wanted to mention, just because it does have direct correlation to your work, Dr. Jean, is I think we've known over the years, like breast cancer and women's health, and just the propensity for women to actually develop metastasis to the brain as a direct correlation and result of that disease. And so those soft tissue, more so determinations, I'd love to see, you know, as surgical theater continues to evolve, they're such pioneers in the space. I'm sure they will develop some type of application for more of the soft tissue and more of women's health inclined work. But I'm very interested to see how that's going to play out in the future too.
Wonderful. All right, so let's go to the audience questions. And I think the next one, Dr. Jean, you wanted to answer that one about how many patients refuse to see the VR surgery experience over fear.
I think I've already answered that. I think it's really not fear. It's really some sort of vertigo or dizziness issues that would have them refuse the VR headset. But again, if they do, looking at that anatomy on the 2D screen is fine, because you can rotate that into a 3-dimensionality on the 2D screen.
So the next one is from Chris Farr, asking about, do you use step-by-step guidance as well? What other sensors or tools do you use? And if I can put into this one, I also had a question that we wanted to talk about the team, like how wide are the team practices? Is it the surgeons, or when you do the practice, does it include the nurses, the other people in the theater, that when you're operating? So just, what are you using in addition, I think, to surgical theater to guide?
For surgical rehearsal, it's just me and the surgical theater engineer. Being used maybe for step-by-step guidance during the procedure. I'm not sure I understand what that means.
That might almost be what you were doing, like that first step, second step, third step, we were talking about robotics, but it's like that kind of, because it could put it in front of you, I don't know.
Right.
But, yeah.
So I can put in markers to say, okay, I want to make sure that this, again, this is like GPS, right? Mm-hmm. We had to use maps before. Now we have GPS. This is exactly GPS. The orange dot tells you to make a left turn. The blue dot, when you get to the blue dot, you make a right turn. And then with the red dot, you make a left turn. So, then, you step by step, I can implant as many of these markers as I want, and it could guide me. Whereas I didn't see those guideposts before.
And that kind of ties to the next question, maybe from Florina. I'm not sure if I'm saying that name right, but so the notion of what do you hide, what can you show? Are there layers when you're doing the AR surgery? Mm-hmm. I think that's like the tool. Does it allow you to turn it on, turn it off? What can you do with that?
Yes, there's a foot pedal that allows me to do that. I can also verbally ask the surgical theater program lead to do that for me. That's absolutely critical, because you can paint in 10 objects, and if you always have to look at those 10 objects all at the same time, it could become very taxing and becomes useless. And in fact, there are older renditions of this technology that does that, and people say, well, this is completely useless because it's just completely, I see a kaleidoscope in front of me, it becomes ridiculous. And
everything's purple because all the colors are, right.
But here you can say, okay, I want to turn on the optic nerve. Okay, there we go. Thank you. Turn off, please. Okay, now turn on my marker number 2. Thank you. Okay, I make a left turn, marker number 2, right? Okay, so turn that off, please. Then the marker number 3, and so it's all completely separatable, and yeah.
So James Lou is asking about the markers themselves. Are they 2D or 3D? And does it matter?
They are 3 dimensions, because you do need to know how deep you are, right? Because so when if my focus is on the marker, it shows it as a circle rather than a sphere. If my focus of the microscope is above that or deep to it, it may show up as a actual sphere, not just a circle. So I do need to know where my focus depth of my microscope is and how far away I am to that target, if I'm talking about just a marker. Pathology, obviously, more involved in that.
Does it add, one of the things we've had a lot of questions about in the past is how to sterilize if it's in the sterile area that has to be sterilized, and does it add additional equipment for you to wear as a surgeon? Like, how do you get used to it? How long did it take you as a new surgeon using it? Would it be adding a lot to what you're wearing? Would it enter the sterile field? Would it, how long does it take to get used to it?
My nurse was asking me today what are the disposables. There's nothing. There's nothing disposable, nothing equipment-wise that's in the field, because everything is projected into the ocular or the microscope.
Yeah. Yep.
What you do have to get used to is that the projected images is only on the left eye. So, if you're, it can throw you off, like, whoa, what, this is very, it can cause some surgeons, I guess, a little bit of vertigo too. When that happens to me, I just say, just tone it down, meaning that you turn the transparency up so that the injected objects are not as opaque. Then you say, okay, good. There we go. Otherwise, sometimes it does get a little bit dizzying, even with just one marker or two.
Yep. I mean, a lot of the AR glasses have that too, just for hobbyists. It's just one eye, and you have to tuck your brain into feeling like it's in both eyes. Yeah, sort of.
As far as sterilization goes, you know, from my perspective as a patient, another company, Amy Kendrick, that created Clean Box technology, you know, she really is such a huge front runner right now with COVID, just providing that next level of sterilization as the device is used from patient to patient.
Yeah. And then we've had people say just good old fashioned wiping them down properly works for headsets, you know, right? But the Clean Box is pretty great. So I have a question from Stephen about cost. So he's saying to acquire the equipment and what you need in the operating room and to prepare for it, what's the estimated investment for an organization?
Invaluable.
But what do they have to shell out, I guess is what they're asking. Yeah. And that just may be more of a question for surgical theater, but is there a ballpark that you feel comfortable sharing?
I think it's
that's for surgical theater, and as well as the people who write my paycheck, because they just wrote the same. They wrote the same paycheck to surgical theater just recently. I'll let the other folks answer that.
Mm-hmm.
Okay. And so I just tell people that in the chat, some folks from surgical theater have just put their email if you want to ask that kind of cost question to them too. So let's see, I have 2 more questions and then I want to close it out with letting you have last word. When you're watching the VRX, how anxious were you? So this is direct to Danielle. Like, how'd you feel about it?
Exactly the opposite. So prior to putting on the headset, I would say I was the most anxious I've been, quite frankly, in my entire life. And putting on the headset, like, it does something. You know, first of all, if you have the capacity and the ability to be in that 3-dimensional environment, one of the greatest things it does is that it cuts everything else out. I mean, for those moments, I forgot that I was in a hospital room. I forgot that I heard, you know, clicking and that I had IVs all in my arms. And I was just looking specifically at what needed to be tackled. And it was, you know, just a one-track mind, hearing my surgeon's voice and then going through the images with him. So if anything, it had the exact opposite effect that being in the headset brought the most peace that I had felt throughout that course of my 10-day stay, other than maybe when I was under anesthesia. But yeah.
And I take it that this is a very collaborative walkthrough, like you and Dr. Jean walking through it at the pace that works for you. Is that
yes, very much so. I have it on video, so I've played it a couple times. The actual footage, but I remember Dr. Jean saying something, you know, about like the tumor, and I was like, there's no tumor, you know, and he quickly was like, no, the AVM. And it was just like a comical moment because we were engaged in it together and we were going through it as a team. And, you know, so often it's the white coated doctor bestowing his wisdom upon the patient, and the patient just kind of sits there and takes it all in, but doesn't fully comprehend or understand. And in this capacity, it didn't by no means put me on a level playing field with his intellectual capability, but it allowed me to see as he sees. And for a patient, that's such a critical part of signing on for any procedure, is the capacity to fully understand and ask articulate questions with your surgeon, to which degree it gave me that.
So we're coming to the end, and I want to make sure that you guys, given what we've covered, if there's anything else that you'd like to share or talk about that you're surprised didn't come up or you want to say, yeah.
I just want to piggyback on Danielle's last answer. You know, in the old days, by the way, brain surgeons are not intellectuals. You're mistaking us for rocket scientists.
Aren't you both?
We're quite dumb, and very literal.
I'm a rocket scientist, and I know you're not dumb.
Here's the thing. In the old days, you know, patients had surgeries because the doctors told them they need surgery and they should have surgery. In the last decades or so, patients have become much more of a partner, and they want to take part in their healthcare, which is completely the right thing to do. Problem has been that they don't have a medical degree and they don't see what we do, and we have difficulty explaining exactly what we think, what our experience tells us, And so, yes, patients should be part of the decision making and participate in their healthcare choices, but they don't have medical degrees, and there's sort of the standoff. Anything that can help the patient level that playing field, come to an understanding of the need for intervention and the rationale for management, helps both parties. So this is a critical piece of technology, and I really think it needs to be widely applied.
Wonderful. Any other final comments? I think we've covered everything. So absolutely wonderful. I want to thank you both for your time today. And we're really delighted to have you. And I can't imagine who hasn't learned a lot today. And there's, again, for the audience, these people are available. You're publicly, we can find you. They can find out more about the research. And this has been recorded if people have been asking about that, and it'll be up on the website within about a week and a half or so. So thank you guys very much for taking your busy time and for helping everybody be far more educated. And we got to go forward and not be barbarians in the future of our surgery, right? That's what I'm like, go, Dr. Jean, go. So
thank you.
Wonderful. All right, guys. Thank you all. Yep.
Thank you.
Bye-bye all. Cheers.
Bye-bye.
Thank you for the audience questions. They were fantastic.